Good afternoon, everyone, and welcome to the Support Hospital Opioid Use Disorder Treatment Shout Texas Echo. Please note that we are recording these sessions for later distribution. Please know that anything listed in the chat will not be shared in the recording. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, email, and affiliation into the chat function. To access the chat, please click on the speech bubble icon at the navigation bar at the bottom of your window. To all the BeWell Texas providers, please make sure that you identify yourselves during the session, or if you're joining via phone, please email your name and phone number to bewelltx@ithaca.edu. Some housekeeping, please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is at the bottom of your Zoom controls. If you're on the phone, just press *6. We also encourage you to unmute and speak, especially during the discussion portion of the session. We want to hear from as many of you as possible, so please keep your comments brief to allow time for others to speak up. You can also use the chat feature to share your comments and questions. Please note that no protected health information is allowed in either the chat or our discussions, and this includes any mention of names, email addresses, phone numbers, or anything that can easily identify an individual. If you'd like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. Towards the end of the session, the Shout Texas Echo team will send out a link to an evaluation survey. All participants filling out the survey will be entered into a raffle for a $30 Walmart gift card. Our didactic today is on how to meaningfully engage trainees in caring for patients with SUD, and this will be presented by Dr. Nick Christian. Following that, we will discuss a case presented by Dr. Zachary Freeland and Dr. Yishao Chen. We will start with some introductions, followed by didactics, BeWell program announcements, case presentation, and open discussion. Thank you all again for joining today's Echo. In the spirit of all teach and all learn, I encourage you all to share your experiences, questions, and insights in today's conversation. And with that, we will do some introductions. Dr. Christian.
Yes, hello everyone. My name's Nick Christian. I am currently a physician at the National Institute on Drug Abuse, but I was formerly in Austin, Texas, and I was a trainee, a resident trainee, when the buprenorphine team, or B team, was getting started. So that's how I got connected to y'all. So it's great to be here.
Thank you so much for joining us, Dr. Ramesh.
Hey everyone, I'm Jan Ramesh. I'm a hospitalist at Del Seton Medical Center. Happy to be here.
Thank you so much. Dr. Lindsay.
Hi everyone, Adrienne Lindsay. I direct the Center for Substance Use Training and Telemetry at BeWell Texas at UTL. Thanks for being here.
Thank you. Alana Bolton.
Hi, good afternoon, everyone. My name is Alana Bolton. I'm the director of Shout Texas at the Dell Medical School at the University of Texas at Austin. Thanks so much for joining us today.
Thank you so much. Dr. Freeland.
Hey, Zach Freeland. I'm a hospitalist at Baylor University Medical Center in Dallas. And I'm the our Shout clinical champion and the director for our inpatient opioid use disorder consult service.
Thank you so much for joining us today. Dr. Chen.
Hi, my name is Yishao Chen. I'm a hospitalist over at Baylor University Medical Center. Dr. Freeland and I, we both are co-directors of the internal medicine addiction medicine curriculum for Baylor University Medical Center.
Thank you so much for joining us today. And with that, we will move on to our didactics. Dr. Christian, you can take it away whenever you're ready.
Excellent. Can everyone hear me and see my slides okay?
That's perfect. Thank you.
Great. So good to be here. I gave a similar talk 2 years ago, and man, this group keeps growing tremendously, and it just tickles my heart, Dr. Chen and Dr. Freeland, hearing that you guys have a curriculum under development. I really highly believe that we need to be engaging our trainees earlier on in addiction work. And as someone who has been involved in addiction research, even as a medical student, I hope that I can share some of the insights that I've had over the years on how to meaningfully engage our trainees in this sort of work. And I'm happy to field any questions. I kind of have called an audible with some of the topics that I hope to discuss today, but please interrupt at any time if you have questions about any of the specific projects that I referenced throughout. And I just have to preface that the views that I express here do not reflect the views of the National Institute of Health. I have no financial disclosures. So the goal for today is to kind of help everyone think about how is it that we can identify opportunities to include trainees in our clinical or research setting. And I'm going to mainly focus on graduate medical education, so residents and fellows. How can we devise strategies to recruit these individuals into our clinical or research setting? And then what are strategies to create meaningful roles for these individuals in our care settings? And I wanted to start with a really mind-opening experience that I had as a medical student. I was really involved with the Institute for Healthcare Improvement, and I attended one of their Student Quality Leadership Academy sessions, and I heard this gentleman speak. His name is Marshall Gans. He did a lot of advocacy work during the civil rights movement and was instrumental in recruiting resources to that cause. And I remember hearing his talk, and I had been a part of a couple of other student organizations and even a nonprofit group. And I had been struggling with this idea. And so I was super excited to ask this very simple question. How do you recruit resources towards your cause, Mr. Gans? Like what's the secret to recruiting resources? And he told me this: if resources aren't attracted to your cause, you probably have the wrong cause. And that truly blew my mind. It really changed how I think about what it is that we do as medical educators. If students and trainees aren't getting excited about the topic that you're teaching or doing, you either need to change your perspective on how that's being taught, or make sure that you have a cause that's worthy of people getting involved in. And that, when I was in medical school, it really made me think about what are the things that are important to me. I'm from a small town in Ohio, and unfortunately, my small town was hit pretty hard with the opioid crisis. And so that was true to my heart, and it was starting to affect a lot of the people at my medical school that was just down the road at Wright State University in Dayton, Ohio. And so we started to think about, okay, how is it that we can turn the assets that we have, which for me, I had students that were in our IHI Open School chapter. How can we get them plugged into meaningful change around the opioid crisis? And everyone was passionate about how we could move the needle on the opioid crisis. And at that time, we went from 10 students in our student group to like 50 plus students in a matter of a month. And it was mainly because we changed from recruiting people to, why don't you be involved in our healthcare improvement group, to why don't you be involved in our group that's moving the needle on the opioid crisis. And that I suspect that many of you are in positions where you're doing work around addiction and substance use disorder. And I just want to remind you that we are in a very timely field. And I think that students really are passionate about wanting to be involved in this work. And so it's up to us to think about how can we meaningfully create roles for these trainees to actually make a difference in our patients' lives. And so the things that I learned from that I just wanted to quickly mention is that trainees really do desire meaningful projects. I was a med student at the time, and we recruited pharmacy students, all sorts of undergraduate medical education trainees. That people want self-directed roles, and those are the most impactful, and that trainees actually can meaningfully contribute to our organization's goals. And so I just wanted to go step by step here and highlight some best practices, and then get to some examples to kind of highlight how this has worked for me in with graduate medical education as well. So how do we identify opportunities? I think all of us work in either a research, clinical, or educational realm, and there's varying levels of overlap in those roles. And I would argue that different students are going to be excited about those different areas of overlap. But how do we identify the locations of where our residents could be more involved in our work? These are the questions that I have gone through in the past. Where could I use a little extra energy? What are the areas that are highly prolific and needs published? We hosted focus groups with early people who went through the buprenorphine team or received buprenorphine in the hospital. And we needed hands on deck to help us transcribe that. And it was ripe for literature, and several residents were able to present that data at conferences. So that's just one example of what are areas where you have the data collected, but you need to move it from the data collection phase to data reporting. Where could you use better organization? Where could you use perspective or expertise or skills, or even what are the necessary things that it's imperative that we expose our trainees to early on in their education? And I would argue that all of our work in the substance use disorder field qualify. You could also think through what are on the impact versus effort grid, where is it that you should focus your strategies on creating opportunities for residents? To me, I think focusing first on the higher effort, higher impact realm usually is great, because it's oftentimes hard as organizations to recruit more individuals, especially people that are able to provide services for free. And so creating a way for trainees to support our efforts that are higher in the effort realm is one strategy to move those programs ahead. How do we devise strategies to recruit trainees? This may seem really basic, but it's actually more simple than I think what people lead on. Email, provide free pizza. Free pizza still works for residents. It still works for fellows even. I was just in that situation 2 years ago. Instagram, making announcements, networking. There are two strategies for who to target for this outreach. I think you can either start by hitting them high, which would be starting with program directors, starting with chief residents, or if you are able to just send a mass text or a mass message to the entire Department of Internal Medicine, then you're hitting more people, and maybe you'll find one person, one resident who's really passionate about this work, and you can just start with them, and then they in turn have a network of individuals that they can reach out to. But thinking about that strategy of, do you target people that are higher up on the academic food chain, or do you just go straight to the source? And then to me, I think the most important thing is making sure that we're creating meaningful roles for our trainees. And I have found that the best way to do that is meet one-on-one with people, really get to know why they're interested in our work, and understand more about what skills they have and what content they would like to learn, and what kind of outcome they want. I think it's really reasonable to recruit residents that are just looking for posters or publications, because there are ways for us to understand that, okay, if that's your goal, we have this data that needs collected. It motivates them to be in a situation where they can actually take the lead on a project, and where they understand that, okay, my impact in this project will lead to this outcome. And the unfortunate reality is that posters, publications, networking, and future jobs are a very realistic motivator for trainees. I sometimes use this involvement ruler, like how much we're familiar with the motivation ruler that we often use in motivational interviewing. But I like to think of it, involvement isn't all or nothing. Like, some people are able to give more than others, and really trying to drive down in your one-on-ones with people. How much time are you available? What kind of patient contact are you looking to get? What duration of involvement is of interest to you? And so these were all very broad, generalized strategies, and I just wanted to provide everyone with some examples on how this has looked for me. Anyone have any questions before I launch into some examples, or anything that resonates with you of examples in your arena, or how you're currently engaging graduate medical education students? Great. I will continue on for now. So with the B team, a lot of projects kind of spun off of the buprenorphine team in the early days. For those that aren't familiar, we started by creating an interprofessional team that would screen our patients in Austin, Texas for opioid use disorder, see if they were eligible to start buprenorphine. If they were eligible, then we would start them on buprenorphine in the hospital, transition them to an outpatient clinic at discharge. And so I was a part of the team that helped map out that process and what that workflow would look like as a resident. But there were so many other opportunities to engage residents in this work. I mentioned we hosted focus groups to really try to understand what was the experience of our patients that were getting buprenorphine in the hospital, and why was it that they either were or were not successful when they followed up outside of the hospital. We even hosted broader focus groups just to understand what were the barriers that they felt like they had been presented with in the past to getting person-centered care in the hospital setting. And the data that we collected from those focus groups were actually used to create a sim that we did with our residents and medical students. And it was kind of a flipped sim. So we created a script where the actor was actually the medical provider, and the medical student or the resident were actually sitting in the role of the patient. And one actor treated the person in a person-centered way, very dignified, offered them treatment for their pain, whereas the other actor treated that trainee in a very stigmatized fashion, calling them an addict, not taking their symptoms seriously. And we heard tremendous feedback from those sessions. Well, for one, no one else had ever really experimented with having this flipped sim setting. And for two, I think it really opened a lot of trainees' eyes to how our patients feel when they are getting inappropriate care in the hospital setting. And so we ended up collecting data from those sims, and another resident ended up analyzing that data. And so that's just one way that we ended up engaging other undergraduate medical education trainees, as well as graduate medical education trainees in our work. Other empowering residents to present this work was another priority, and I had tons of support to present this work on my own, as well as there were other residents who helped me analyze some of our data elements. And so any resident who was a part of analyzing this data, we made sure to allow them to present at conferences like SGIM or ACP, SHM, anything to create a line item for them on their CV, as well as give them hands-on experience working with health services research, especially with people with substance use disorder. I just quickly wanted to mention as well that I've been a part of some community-based participatory research. And this was at a village in Austin, Texas called Community First Village, where I lived there during residency. And during that time, I just learned so much from my neighbors and how willing they are to teach and to actually be a part of the research process. And so through that, we developed this wellness advisory board in the community of residents of the community. And community members were really concerned because there was a huge uptick in substance use and overdose deaths early on during COVID. And so we ended up creating a survey, and I worked closely with some internal medicine residents at Dell Medical School to create this, create a survey that we, the residents of the community administered. And the whole, for those that aren't familiar with community-based participatory research, the whole idea is that research is done, every step of the research process is done with residents of the community that you're researching. And so this has been a great opportunity for residents to work closely with people who were once unhoused, people with substance use disorders, and work with them to research together. And we've presented data from this research at many different conferences. I did my addiction medicine training at Yale School of Medicine, and I just briefly wanted to mention they have a really neat program called CHAMP. And I think that this is another, for those of you who are at institutions that are a little more higher level that already have some substance use disorder treatment infrastructure, this might be something to consider. So it's a 5-year training program funded by HRSA with the aim of providing their primary care track residents as well as PA students with interprofessional training in addiction medicine. And so as a medical student, when you enroll in the CHAMP program, you are embedded into, I'll just go so you can see it year by year, you're embedded into specific training around addiction. So by the time that you are done with your primary care training, you are more or less, you've already gone through a curriculum that looks similar to what a fellow would. Many of these CHAMP residents ended up completing the addiction medicine fellowship at the end of their time. And so if anyone's interested in more in this program, I'm happy to provide you with the specifics of these slides and connect you to Kenny Morford, who is at Yale and has done tremendous work in this realm. So just to summarize, we can identify opportunities to include trainees in any area of what we do, our research, our educational work, or our clinical work. Just think through how to devise strategies to recruit trainees and make sure that we're meeting with people to create meaningful roles for trainees. And I thought this quote from Rudolf Virchow, medical education does not exist to provide students with a way of making a living, but to ensure the health of the community. And I really think that right now, overdose and addiction are one of the biggest threats to the health of all of our communities. And I think that we have the opportunity to engage our trainees in this sort of work. So I thank you all for all of your amazing work that you're doing at your institutions. And I'd like to wrap up now and ask for any questions or engage in any dialogue. But thank you so much for hosting me.
Thank you so much, Dr. Christian. It was a wonderful presentation. Now open up the floor for any questions or comments from our learning community here.
I'll kick it off. Weems here from Community Care and UT Dell. Nick, that was fantastic. I think you come at this from a unique place and you bring unique skills to it and have so much to teach us. One sort of takeaway for me was to introduce the opportunity for impact early on and then offer opportunities for learners that are self-directed. You know, you're also a member of a community and have built a lot of trust with Community First Village. And I think a lot of us who are both in the clinical space and making relationships with community partners and are involved in healthcare professional training efforts want to strike an honest balance, you know, and create opportunities for learners that don't compromise, that definitely compromise the quality of clinical care, but then also, you know, kind of speak to the relationships we've formed with community partners in an honest way. And that's kind of high level and vague, but I think it's critically important to maintaining those relationships and offering that authentic opportunity for impact. How do you think about that as a missional at Community First Village and as somebody who's built so much trust in the community?
Yeah, no, you nailed it, John, and thank you for the feedback. It is really challenging when we're spread in so many directions, needing to develop our clinical services, needing to develop our research efforts. And then you have to network with the community members. Like it feels like it's uh, something that's ancillary and it never gets prioritized. But I would argue that those relationships that you build with the people that you work with and the people that you're referring your patients to, for instance, the extra time that you put into getting to know the members of those organizations, it might feel like you're only doing it because it's the nice thing to do, but in actuality, we need to view our relationships with community providers as being it's an investment. I'm investing in this not because it's nice, not because it's the right thing to do, but also because I am showing the community that I trust in you. And it's really interesting thinking about how do you develop that trust. And I really think that the simple things of making sure that you do what you say you're going to do for your community organizations. And for me, that's been the number one thing, developing trust with members of Community First Village is if someone is asking for something and I say, okay, yes, we are going to host a Narcan awareness event, I make sure that I hold myself to that. And it can be really difficult and challenging to be honest with yourself when you have to decline an opportunity because you can't deliver. But those opportunities, when you say you're going to do something and you're actually unable to do it, that's the easiest way to deteriorate trust with community organizations. And so thinking through how can I hold my organization accountable to deliver on the things that we say we're going to do, while also investing in these in networking with these organizations around us that we work with on a daily basis.
Thank you, Dr. Christian. Guess we can move on to the next part of our session. In the meanwhile, please keep the questions coming in the chat, and Dr. Christian is here and he will answer as we go on. Karen, if you could please share the announcements from the Be Well program. Thank you. To claim CME credits for this session, please text attend 1009-5734 to 844-502-1338 by midnight tonight. Next slide, please. Do you have a difficult case that you or your team have encountered? CSTAT offers you the opportunity to present any challenge your organization is encountering and receive feedback from our hub of experts and the broader learning community. There is no need to prepare a formal presentation. We will share a case form to fill out to assist with the case presentation. You can email us at shouttx@austin.utexas.edu. Next slide, please. Join CSTAT for our session titled Mitigating Grief and Loss Post-Pandemic, and this will be happening on Tuesday, May 21st at 12 noon CT. We will be dropping the registration link in the chat. Next slide. Please join us for our next Shout Echo session on Thursday, May 16th. Next slide. The Center for Substance Use Training and Telementoring offers technical assistance for the various SUD needs and topics via a team of experts. To request technical assistance, please complete an online request form and we'll be pleased to help you. And we can drop this link in the chat as well. And with that, we will move on to our case for today. Dr. Freeland and Dr. Chen, you can take it away when you're ready.
Hey everyone, my name is Nicholaus Chen. I am a hospitalist at Baylor University Medical Center, and I will be doing this presentation with Dr. Freeland, who is also a hospitalist. I apologize if there's a lot of noise outside. I am currently in Boston for the American College of Physicians conference, and I couldn't find a quiet place, so I'm just in a parking lot right now doing this presentation. So I apologize for the noise. Next slide. So I was going to talk about our addiction medicine curriculum that we've developed. And then Dr. Freeland will talk a little bit about the assessment that we're using to see if our curriculum is working or not, and some questions that we have from the Shout community to address some of the obstacles that we've been facing. So just some background about our hospital. We are a large quaternary referral center. We have 1,000 or something beds located here in Dallas. We are an academic program. We hold several residencies and fellowships. So Dr. Freeland, he is a hospitalist and also the medical director of our opioid use disorders consult service. And I am the assistant medical director for our hospitalist group, and I'm also the associate program director for our internal medicine residency. But we are hospitalists. We are not formally addiction trained, so we had to seek out these training by ourselves. And thanks to our good friends at Shout, we were able to get our consult service off the ground. So we take consults year round from 8 to 5 p.m. every single day. Our call rotates between 8 physicians and 3 APPs. Our average call volumes is we get about 0.6 new consults per day, and we're seeing anywhere from 2 to 3 consults per day. But that census also varies very wildly as well. Some days I'm seeing 4 or 5 patients, and other days I'm not seeing any patients. And this is kind of things that we're doing on the side in addition to rounding and caring for patients. And we also got the Shout grant back in 2022. Next slide. So the problems that we were seeking to address when we created this curriculum is that there is no addiction medicine curriculum in place for our internal medicine residents. Occasionally they get lectures on pain management through either noon conference or grand rounds, but certainly nothing structured and definitely nothing on addiction. But back in 2022, the ACGME required that all internal medicine residents have addiction medicine as a core competency. They don't explicitly say how this needs to be done, like how many weeks do they need. They just say they just need some clinical experience. Furthermore, in 2023, the DEA is now requiring 8 hours of training on opioid use disorder or other addiction medicine or pain medication before providers can get their DEA license. Next slide. So what we ended up doing is we created a addiction medicine elective for our internal medicine residents. Basically, we took 2 weeks out of their existing 4-week palliative care rotation. And through that, we have our residents rotate with our opioid use disorder consult service. We also have them observe at a local behavioral health clinic. And then we also give them 6 hours of self-directed learning because the census varies quite widely. So sometimes they have a lot of downtime. So we say, hey, in your downtime, why don't you just read some articles, listen to these podcasts and videos. Next slide. We've created some learning objectives that we assess the residents with. We try to make this both practical, actionable, and most importantly, measurable. I'm not going to read all of them through, but I'm going to just hit some of the highlights. We want our residents to learn how to do a comprehensive substance use history. We want them to be able to do harm reduction, including knowing how to give naloxone and screen for infectious disease. We want them to be able to learn how to titrate buprenorphine and methadone in the hospital setting. And we also want them to learn about medications for alcohol use disorder as well. We wanted them to become aware of their own attitudes and beliefs and how this might affect stigma when it comes to their patients. And we also want them to be able to communicate with our social worker and figuring out a good plan to get these patients outpatient follow-up. Next slide. So just kind of give you guys an idea of what it's like to be on the service. So on day 1, I spent about an hour or so to orient these residents to this rotation. I kind of go over how we diagnose opioid use disorder. I give them a brief introduction on how do we do buprenorphine inductions, and then I give them some handouts, including 2 New England Journal articles that we expect them to read. We talk a little bit about motivational interviewing, and a lot of this is also done through a template that we shared with them beforehand. So as they kind of go down through the template, they kind of do a little bit of motivational interviewing through it as well. We discuss stigma, and then also teach them about how to counsel patients on harm reduction. And then I also show them how to use naloxone, and I show them, because we have a whole box of naloxone that we try to give to as many patients as we can. And then we also kind of go over their expectations, such as seeing both new consults and following up existing patients, and dosing buprenorphine and methadone, and following up with social worker. Next slide. For our behavioral health component, so we partner with Homeward Bound. They are a local nonprofit health agency They serve the patients in the DFW area. So this is a purely shadowing experience because residents cannot be supervised by a APP. So the residents here, in this case, observe a nurse practitioners who do mental health counseling and treatment, and they also do addiction medicine treatment as well. Mainly opioid use disorder, but they also occasionally do alcohol use disorder as well. There is also a group therapy session that we invite the residents to observe. Next slide. And then this is where that goes.
Yeah, I'll take over here. Thank you, Dr. Chen. So not only do we have no formal training in addiction medicine, we also have no formal training in curriculum development. So we wanted a way to kind of measure the impact of what we were teaching and try to use that in addition to feedback solicited from the residents to improve this curriculum moving forward. And I'm not sure if Dr. Chen said, but we just started this back in November. So we've only been going for about 5 months now. So we created an anonymous optional self-assessment kind of survey/test that the residents complete prior to beginning the addiction medicine elective. It has 14 questions that are measured on a Likert scale from 1 to 5, kind of that map directly to that long list of learning objectives. Basically, and I'll show you an example, basically assessing their comfort level or their experience with each of those kind of competencies that we want them to have. And then after completing the 2-week rotation, we then ask them to basically do the same assessment again. And so we're looking at how they hopefully improve in each of those competencies. And we used Microsoft Forms for this, very similar to Google Forms. So far, we've had 9 residents complete the rotation. We got 8 to do the pre-elective assessment, and 6 have done the post-elective. Again, we made it optional, so we didn't twist any arms too hard. This is just an example from the first part of the assessment. And so as you can see, saying, I feel comfortable taking a comprehensive substance use history, identifying risk factors for overdose and infectious disease transmission. And then the resident says, I'm not at all comfortable, all the way up to I'm extremely comfortable with that for each of those 14 things. And then there were also a few just kind of sample test questions, giving them a clinical scenario and giving them a multiple choice answer for that. So this very busy slide, but these are those 14 questions that map to each of those learning objectives. The shaded bars show the responses, where the darker color to the right is more, better, more confident, more comfortable. And the pre-rotation assessment is on top, and the post is on the bottom. Really, the money is in that far right column where it shows the change. And so fortunately, we actually saw a change in all of the 14 questions that we asked. I want to highlight just a few where we saw the biggest change, which is in the residents' confidence in safely and effectively initiating buprenorphine in the inpatient and outpatient settings. And that was really one of the major things that we wanted to teach, because we wanted to give the residents this tool to, regardless of what specialty they go into, to have in their back pocket. And so I think we were successful in teaching that skill and how to use that tool. Also, they reported significant improvements in their comfort level in educating patients on the use of Narcan, and then also in coordinating with comprehensive care management to connect these patients with the appropriate outpatient resources. So some feedback that we got, and again on the post-rotation assessment, it had some open-ended questions. So some of the positive feedback we got was, and these are all direct quotes, I like learning about inpatient initiation of bup. I found the inpatient rotation and discussions with the OUD team very helpful. The inpatient portion helped understand managing withdrawal symptoms and dosing buprenorphine. Thought it was valuable to see patients with different socioeconomic backgrounds and medical barriers, and then enjoyed using Dr. Chen's consult note template. And one of the self-directed learning things that we recommended was the Curbsiders Addiction Medicine podcast. That was enjoyed. Some of the more negative or constructive, as I like to call it, feedback. I wish that more of the learning resources were written rather than videos and podcasts. I don't feel the structure of the rotation is working. Again, this was combined or kind of carved out of the palliative care rotation. And so some felt like there was just too much conflict between the two, and that it would be better if those two rotations were just completely separated. And then some felt that Homeward Bound wasn't a terribly useful part. That was the outpatient behavioral health clinic, where they're seeing both patients with purely mental health and substance use, and also dual diagnoses. They felt like there wasn't that much OUD and substance use management, and a lot of the patients were very stable and would just come in and get their, hi, how you doing, get their prescriptions written. Some sources of success. And so absolutely critical was getting buy-in from internal medicine program leadership, as well as our hospital medicine leadership. I mean, it certainly helped to have Dr. Chen be both the elective co-director and a member of the OUD team with me, but also being an associate program director for the residency program. So having someone like that, like Dr. Chen, was really beneficial. We also had very gracious support from Homeward Bound, letting us send our residents there to shadow and to learn, especially since we don't have really any kind of addiction medicine or addiction psychiatry in the Baylor Scott White system in North Texas. So we had to look outside for that, and we're grateful to be able to partner with Homeward Bound. It's also important to have the faculty, the hospitalists who are going to be working with the residents, orienting them ahead of time, sending them reminders that, hey, this resident's going to be working with you next week, so that they're ready and they're expecting the resident and kind of picking out patients for the resident to see. And so that the resident isn't just like showing up in the afternoon as kind of an afterthought. And then it was also important to share we have these consult note templates that have a lot of just kind of templated stuff about kind of walking through the process of initiating BUP, that is helpful for them to kind of frame their discussion of the problem and their management. I mean, it kind of helps them hit the ground running when they start. So some obstacles. So on the inpatient side, again, we have 8 physicians and 3 APPs on our team, and ACGME standards dictate that inpatient resident physicians can only be supervised by physicians with rare exceptions. They can't be supervised by APPs. So even though our APPs are highly valued members of our team, it required us to do a little bit of finagling. We try to make sure that on the days when we have a resident, that we have an attending pair with them and not an APP. But there definitely is a little bit of conflict there, because we don't want to marginalize our APP members, and honestly, we need them. So we can't. It's not like we can shut them out completely, and we don't want to. The patient volume, as Dr. Chen alluded to, is highly variable, and sometimes there just weren't enough patients to fill an afternoon. Also, there were times when we had more than one resident at a time on the rotation, and then you're having to try to have one on one, some days, and one on the other days, and that even further cuts down on the volumes that they're able to see. Hospitalists are busy, and finding time to teach can be challenging, just kind of depending on how the day is going and how our census is. And especially on the inpatient side, with our OUD consult team is very heavily opioid use disorder based. There wasn't as much time spent on alcohol use disorder and other substance use disorders. And then on the outpatient side, ACGME standards do allow supervision by non-physicians in specialized clinics, including like mental health or behavioral health and substance use treatment. So this was kosher, but there, just because of how training pathway from between physicians and nurse practitioners is just very different. It's hard to ensure the experience level of a nurse practitioner, and to ensure that they are kind of well enough beyond the level of the resident in terms of experience to be able to effectively teach them. And there were some residents of the feedback that expressed a preference that they would rather be supervised by physician rather than a nurse practitioner or a physician assistant. And then one thing that we haven't really touched on, but residents have their own continuity clinic that they do throughout their 3 years of training. And historically, they have never done or really been able to do medication-based treatment for OUD there. That has a lot to do with just kind of the familiarity of the attendings who staff that clinic, and kind of their comfort level. And we haven't really scratched the surface of this, but it's never really been kind of considered that we might be able to do some OUD treatment there. So the questions we have for the community, number one is, what are some other ideas for substance use disorder, or specifically opioid use disorder treatment settings that would be useful to resident physicians, particularly with physician supervision? And that is I think it's kind of a rare thing up in our area. But if anybody is up in the DFW area, or if anybody has ideas for kind of telemedicine or virtual options, I'd be happy to hear those as well. Number two, what does the community think about offering medication-based treatment in a resident continuity clinic? Has anybody ever done that or seen that done before? And then number three, how have other internal medicine and family medicine residency programs met the ACGME required experience in addiction medicine?
Thank you so much, Dr. Freeland and Dr. Chen, for your wonderful case presentation. I see we have a question here. Tonya.
Actually, I have a response to the, I'm Tonya with Texas Clinic Healthcare System here in Houston. We are the largest OTP here in the Houston area. The question about clinical settings, we are actually going to start having resident students and third and fourth year maybe, residents doing a short round in our OTP under the supervision of our addiction psychiatrist. So it's something that you all might investigate, contacting U of H, because we're actually starting that program here, and they're going to start doing a rotation in our OTP, working directly under our medical directors and addiction specialists to learn about methadone, Sublocade, Vivitrol, buprenorphine, how we operate that on an outpatient setting, what that looks like from a clinical setting with counselors, with recovery support services, and giving a global care to our OUD and AUD clients. So y'all reach out to U of H, because we're doing it here in Houston. We're going to be starting it, and we're the largest OTP here that will be sponsoring that.
Cool. That's a great thought.
Thank you. Any other questions or comments from the community here?
So I'm with Nexus Recovery Center, and we already have an outpatient OUD program. We treat both alcohol use disorder and opiate use disorder. And we conduct the sessions, whether they be counseling sessions with me or our group counseling sessions, all virtually. And then she would come in beginning every other week to pick up her medications, give a UA. And then as she progresses in the program, she picks up once a month and then and gives a UA, and that from there forward. So we actually have clients as far as San Antonio and Austin who come in once a month to give their UA and pick up medications, all funded through the state. And Nexus is in Dallas, Texas.
Sherry, what kind of practitioner do you have in your clinic?
We have multiple practitioners. We have Dr. Julie Pittman. She is a psychiatrist, and we have two nurse practitioners, Stephanie Lamantia and Elizabeth. I can't think of her last name. So we got three people who actually write the prescriptions.
Okay, cool. Good to know. Thank you.
You're welcome.
I see a question here in the chat from Yunxi. Would you be able to share some of the faculty development resources? Oh, here you go. Okay. Thank you, Dr. Beams.
Thank you for sharing that, as we don't currently have any faculty development resources for the faculty who lead our addiction medicine curriculum. It's just me and Dr. Freeland.
Mm-hmm. But what we do have is we made kind of a curated list of different journal articles and podcasts and videos, and for the residents, but also ones that we've ourselves used to learn, and that we try to get our other hospitalists to look at. And some of those are from the PCSS videos that Dr. Weems posted the link to. And also, like I mentioned earlier, the Curbsiders podcast is another good one. I can vouch for both of those.
Hi, this is Yun. I was asking the question. I'm here with the family medicine residency program in San Antonio. I had asked, I guess I have encountered many training programs, wanting to start curriculum for outpatient management, like similarly like where you are in different conferences I went to. So I've heard different models being proposed or used. There are places they have, I guess, high prevalence of opioid use disorder in the population. They are able to dedicate to do their own single, or I guess specialty clinic in a way, like multiple times in a week. And then there are other more integrated models, like they can be in their continuity panel already, one or two, making sure they're seeing the same providers. But I think a lot of that goes into the faculty's experience and comfort level and all the clinical support and leadership. So it's not as easy as, just go start. I think, definitely I can see where your question is coming from. I think I don't have a lot of experience myself, so I'm also interested in helping our trainees get all the exposure and education. And I do think if by utilizing the local networks, if you have a psychiatry or substance or fellowship trained addiction medicine faculty to take the lead on getting this started. It depends on also how many patients are currently encountering in the clinic already have this issue versus recruiting more patients to come to your clinic. So those are some challenges I can see, definitely. Thank you.
Those are really great points. I think historically there's not been a lot of need, but then also, if you can't or won't address the needs of a patient with OUD, they're not going to be your patient for very long. So we probably have to do some kind of formal needs assessment to try to tease out like how much need is there, what kind of volumes would we be seeing if we had that option in the clinics. And then try to figure out who would staff them.
Yeah, if you follow up on the patients you already started inpatient buprenorphine treatment and see where will be cared after discharge. Might be something to start.
Yeah, we'll have to talk about that. Because yeah, we certainly have a lot, probably most who don't have a primary care physician and would probably benefit from following up in our resident continuity clinic. We haven't historically referred them there, but that could be an option.
And I think you also touched upon something that's very important as well. Like the faculty who's administering this curriculum needs to have a good amount of experience with opioid use disorder. Our opioid use disorder service has been around since 2021? Zach, was that when we started it?
I started seeing patients in 22.
22. So we have at least a couple of years of experience. We definitely did not feel comfortable starting up a resident curriculum right as we were launching our opioid use disorder curriculum. We definitely need to get all the faculty a little bit more comfortable with prescribing first before we start teaching our learners. And I also heard from the ambulatory side, the Johns Hopkins curriculum and the Yale curriculum both have a good amount of addiction medicine as well. So if you have access to that, that might be a good place to start getting people familiar with it.
I see a question from Kristen Clancy in the chat. In addition to the medical training, please provide anti-stigma training, especially strategies for professionally talking with preceptors or co-workers who do not treat these patients with kindness. It's a great point. Thank you.
Yeah, super important, and we do, we do try to incorporate that into our curriculum.
Thank you, Alana, for dropping that resource in the chat.
Yeah, I'll just briefly mention. So we at DelMed created and offer free online stigma reduction modules at resetstigma.org. I put the link in the chat. But very specifically, these modules include interactive exercises, one of which is literally like a case study on how to talk to attending or coworker clinicians in the healthcare setting about using stigmatizing language or behaviors. So I think hopefully that kind of fits what you were asking for, Kristen.
Thank you. This has been a wonderful discussion, but in the interest of time, we will have to move on. Dr. Ramesh, could you please provide us a summary of today's session and the case?
Thank you, Dr. Freeland and Dr. Chen, for presenting this case. It sounds like you've done a lot of amazing work in setting up a great experience for the residents in multiple settings. And I'm happy that you've done a needs assessment to figure out how you can expand your curricular opportunities for them. We discussed a few methods and resources in Dallas that you could potentially reach out to enrich their experience. Talked about focus groups, as well as making attendings a little bit more comfortable with the stigma and the prescribing of buprenorphine. And I wish you guys luck in continuing to expand your offerings for your residents.
Thank you so much, Dr. Ramesh, and thank you again, Dr. Freeland and Dr. Chen, for bringing this wonderful case. And thank you all for joining today's ECHO. As a reminder, to earn C credits, please take the activity code 1009 5734 by midnight tonight. We also request you to complete the post-session survey using the link in the chat. This survey link will be open for 1 week. If you would like to present a case, please email shouttx at austin.utexas.edu. We look forward to seeing you at our next session, which will be on Thursday, May 16th. Have a wonderful rest of your day. Thank you so much.